Hello there, everyone, and welcome to our webinar. Appreciate you taking time to join us for this event, which is being sponsored by Abbott, Interpreting Right Heart Cath Data to Remotely Manage Heart Failure Patients by Dr. Terry Ann Benjamin. That is the event that you have tuned in for. Dr. Benjamin is an advanced heart failure and transplant cardiology physician at the East Division of the M Health Fairview Heart Care System. Prior to joining M Health, she underwent medical training at the Cleveland Clinic Foundation, trained in internal medicine, general cardiology, and advanced heart failure. Medical degree was obtained at the Icahn School of Medicine at Mount Sinai, master's degree at Johns Hopkins Bloomberg School of Public Health, and bachelor's degree at Yale University. What I want to do as we begin here is share a few of our housekeeping items. At the bottom of the screen, you're going to see multiple application widgets that you can use. Those are all resizable and movable. I encourage you to move those about the screen. Get the most out of your desktop space there. If you do have questions during our webcast, really encourage you to submit those through the Q&A widget. We're going to do our best to get through as many of those questions as possible. Most likely we'll have most of those stacked towards the end of the event, but if there's something you're looking for clarification on, feel free to get those questions in early and often. For the best viewing experience, recommend using a wired internet connection. Also, you can close down any programs or browser sessions that are running in the background that could cause any issues. We do recommend using Chrome as the browser for this platform. There are some other additional answers to common tech issues. You'll find that in the Help widget at the bottom of the screen. Give you a little tip here that refresh of your screen typically fixes most issues. At the end of the call, we're going to have a brief survey. I'll mention that again towards the end, but we would really appreciate your feedback on ways that we can continue to improve the programs that we bring you in the future. With all of that, we have a lot of content that we want to get to, so I'm going to step away and turn things over to Dr. Terry Ann Benjamin. Dr. Benjamin, the floor is yours.
Thank you. Hi, everyone. Thanks for joining today's webinar. Today, I'm going to be talking about PA pressures. We're going to be doing a bit of a recap about the pressures and how they're related. And then we're going to go into how they can help to guide management, and specifically looking at some new tools for our toolkit as far as using the PA pressures to take care of our heart failure patients. So what the objectives of this talk are threefold. At the end of the discussion, you should be able to evaluate intracardiac relationships using the right heart cath data, gaining an understanding of the numbers and their relationship to volume status. You should be able to discuss how PA pressure guidance can address volume as well as vascular resistance. You should have developed an idea of potential treatment strategies when diuresis is not an option, and specifically we're going to talk about afterload reduction strategies during this talk. So let's do a little bit of recap, looking at the intracardiac pressure relationships and how they correlate from one chamber to the next. As we talked about in the past, we expect that there should be some concordance between the chambers and the pressures. If we take a view of things through the right heart cath tracing, as if we were in the cath lab and looking at the pressure waveforms, we expect that when we enter the right atrium, we expect to see a pressure about 0 to 8 mean, and then once we move into the RV, we expect to see pressures of systolic 20s to 30s, diastolic 0 to 8 millimeters of mercury. And we expect that between the RA and the RV EDP, the RV end diastolic pressure, we expect to see a concordant relationship as when we see our pressure tracings, whether it's in an ideal patient or in our heart failure patient. If we move on from the RV into the pulmonary artery system, we can look and see that the RV systolic pressure is expected to correlate with the PA systolic pressure. There should be some sort of relationship between those two, some sort of concordance. If we move on into the pulmonary capillary bed, we'll expect to see that the PA diastolic pressure will correspond to the mean pulmonary capillary pressure. And now that we've talked about the overall relationship, what's interesting to see is how they relate to each other when we have these changes or these shifts in our heart failure patients or our patients in general. You know, if one pressure value changes, we should expect that the others change according to that relationship. So for instance, if the wedge pressure rises, what would we usually expect in the normal functioning physiology of the heart to happen to the PAD and the RA mean? We'd expect that the PAD would rise proportionally, and we should see that the RA or the CVP also rises proportionally. We don't expect it to rise as much because we didn't start out with it being as elevated, but there should be some sort of proportional relationship between the three. And that gives us an idea when we're looking at one chamber versus the other, where we are as far as the filling pressures and the volume status of the patient. So if we see pressure tracings and we see that there's a significant difference between one chamber to the next, if we don't see that concordance between the RA and the RV EDP and the RV systolic and the PA systolic and the PAD and the wedge, then we should question normal physiology. We should step back and think, what is the issue? Is there a high fidelity in the tracings? Are the tracings accurate? So are we getting the right data, the right information? Do we need to reassess the right heart cath and make sure everything's leveled? Do we need to make sure that there are no underlying structural abnormalities that could lead to this? And there are some that can occur. They're rare. For instance, tricuspid valve stenosis, pulmonic valve stenosis. And then there's the occurrence where we have elevated or after long-standing elevated LV pressures or left-sided pressures that we can see an occurrence of precapillary remodeling, so elevated pressures on the right side of the heart, which can lead to this discordance between the PAD and the wedge and making it not the best surrogate in that situation. But under normal circumstances, we should expect the relationships from one chamber to the next to be concordant. And we should be able to use one set of information to get an idea of information in other parts of the heart. And so we looked at the tracings and we talked about those intracardiac pressures. And we get all these pressures have different components to them, different characteristics. So the waveforms that we're seeing as a result of these chambers all look distinctly different. And it's very useful, especially if you're in a situation where you don't have a way of visualizing where exactly that right heart cath is. And then a lot of times if we're doing this at bedside or in less than ideal situations, we can use the waveform to get an idea of where we are in the heart. So the atria typically has an A wave, a V wave, and a mean, and the mean is what we usually use to correlate to the RV EDP. The ventricles tend to have the systole, diastole, and diastole portions of the waveform, and then the arteries, like the P arteries, has the systole and diastole and the mean portions. So now if we take a closer look at those waveforms, just to identify those components that I just talked about. So we're looking at the RA, and so we have the A wave, which is the peak following RA contraction. We've got the V wave, which is the peak during atrial filling. And then we've got the mean, which is what we usually refer to when we talk about a CVP or just RA pressures in general, which is the average of the atrial pressure. And it will generally line up with the start of the V wave. We'll start on the V wave upstroke. If we take a look at the RV systolic pressures, or RV pressures in general, the systolic pressure is the peak, as would be expected. Diastolic pressure is the bottom of the waveform, and then the end diastole, which is what we usually correlate to the RA mean, is the moment of maximum diastolic filling right before the ventricle begins to contract. And moving on to the pulmonary artery pressures, we've got systole, diastole, and the mean is actually an average using a certain equation because the heart's in diastole a little longer. And looking at the wedge waveform, very similar to the RA because it's basically a representation of the LA waveform being reflected back to us. So it's measured in a similar way. You've got the A wave, the V wave, and then the mean of the two is what we usually refer to when we're talking about the wedge pressure. And just to recap, we've got our RA mean, which it should be concordant with or proportional to the RV EDP. we've got our RV systole and our PA systole. Those are pressures that we expect to be also in accordance with each other. And then the terms that or the variables that we use quite often in our day-to-day, we've got our PAD and our wedge, which we expect to be congruent. So what about our heart failure patients? When we're looking at our heart failure patients, we shouldn't expect much or any deviation from those relationships. We do expect that the baseline numbers may be a little bit higher, and even with our best efforts and in our most optimized heart failure patients, we tend to have some elevation of these pressures, just right above upper limit of normal, just a little, or just at upper limit of normal. But overall, we still expect to see that the RA mean, the RV EDP should correlate. We still expect that the PAD and the wedge would correlate. And then we expect, of course, RV systolic and the PA systolic pressures to correlate. So the interrelationship of those cardiac pressures should remain true, with the exceptions that we spoke of before. And if they aren't true, then we need to start investigating further and see what else there is that we need to do to optimize our patient. So the one very interesting point that we should highlight is that the PA waveform is very unique, because not many things in cardiology can give us like information of both sides of the heart at the same time. And so the PA waveform is unique in that it tells us what's going on the right side, because we can look at the PA systolic and we can get an idea of what the RV systolic pressure is. And then we can also look at the PAD, and then we can get an idea of what's going on as far as the filling pressures on the left side of the heart. So looking at the PAD and estimating the wedge, then we can estimate the LA filling pressures, and then we can get to our ultimate goal of figuring out the preload, which is the volume status of the heart. So overall, we can, by looking at the PAD, which is an estimate of the wedge, just to summarize things for you guys, and this is also like a good reference point to go back and take a look at these relationships. And that's an estimation of the wedge's estimation of the LA pressure, which estimates LV EDP, which is our ultimate goal, because this is where we go back to that relationship of pressure being a surrogate for volume. Because ultimately, the LV EDP is what we're trying to estimate, which gives us an idea of the preload, which is the loading status or the volume status of the heart. So we can use the PAD as a function of the LV preload. So how to use the PA mean? And so the PA mean is part of the general information we get when we are doing our monitoring, whether it's a right heart cath or whether it's ambulatory and we're using a CardioMEMS. We've focused a lot on the PAD and how it relates to the wedge, but here we have one additional tool in our toolkit that can go a long way as far as managing our heart failure patients. But before we talk about the PAD of the PA mean, we need to talk about a very important component or variable, which is afterload. And the afterload of the heart is the resistance that the ventricles must overcome during ejection. And specifically, since we're talking about PA mean, we've talked about the RV afterload, because that's primarily influenced by the PA pressure. And overall, if there's increased RV afterload, then this can lead to RV failure and decreased cardiac output. So if the RV afterload is primarily influenced by the PA mean, this means that being able to get accurate PA mean pressures and then be able to somehow modify them or facilitate lowering them would mean that the RV would likely not have to worry about this increased resistance or this increased pressure that it will see that will cause it to have to work harder. The harder that the RV has to work, the likelihood that they run into problems. And we're going to talk a little bit more about the PA mean and afterload and how those two come together as far as like our LV systolic failure patients and overall heart failure patient population. So the afterload is resistance, is a great concept, but what is the tangible form? Like, how do we use this information on a day-to-day basis when we see our patients? And how does PA mean directly correlate to this resistance, this afterload? And that's where these equations and formulations come in, and it gives us a very visual idea of how the PA mean plays into it. Instead of me just saying it, you get to see it. So when we're looking at afterload, especially RV afterload, we factor in things, or we need to calculate things such as the transpulmonary gradient. And that is you guessed it, pulmonary artery mean minus another very familiar mean pressure, the pulmonary capillary wedge pressure. And that gives a transpulmonary gradient, and it is what it sounds like. It's the gradient, the difference, basically between the left and the right. And then it tells us how much work, or how much resistance, how much load the right side of the heart has to overcome to basically get blood flow to the left side of the heart. And so when we have that transpulmonary gradient, the next thing we do is we divide it by the cardiac output to get the PVR. And that's important because that's unique to patients. The cardiac output, like the cardiac index, will vary from individual to individual. So it gives us specifically what sort of load that RV has to overcome. So from a criteria standpoint, TPG, or transpulmonary gradient, greater than 15 is considered to be abnormal and should be clinically evaluated. And likewise, a PVR greater than 3, greater than or equal to 3 is considered abnormal and should be taken into consideration as well, especially because we know that the RV can handle volume, but it's not very good at handling high pressures. So we want to make sure that we're optimizing things so we're not setting it up for failure. So we're going back to the PA mean and using it as a surrogate for RV afterload. So this comes in particularly important when we talk about things such as pulmonary hypertension, and we're going to dive into that a little bit more. Today we're going to be talking about pulmonary venous hypertension, or postcapillary hypertension, or pulmonary arterial hypertension, which is precapillary. So pulmonary hypertension in our patients that have left-sided heart disease, or LV dysfunction, whether it's diastolic, systolic, tends to fall into the WHO Group 2 category. And there are multiple WHO groups, but our patients tend to usually fall into the Group 2. It's very common. And unfortunately, there's a pathophysiologic relevance, and it's highly prognostic when there is this left-sided hypertension. It's been found that a PA mean greater than 20 correlates to a 5-year mortality of 62.4%, which is staggeringly high, especially in our patient population who already have a lot of other comorbidities that we're trying to tackle. So LV failure, so WHO class 2, or elevated LV filling pressures, whether it's volume or pressure shifts, leads to pulmonary hypertension. And guess what? That leads to an increased PA mean, which means that leads to an increased resistance, so increased work for the RV to have to overcome, which can ultimately lead to RV failure. So as I touched on before, our Group 2 patients are patients with left heart disease, which are primarily the majority of patients that we see in our practices, or that we're treating in our practices. And they are the left-sided dysfunction, whether it's systolic, diastolic, whether it's secondary to coronary disease, valvular disease, congenital. And in these patients, what we try to do is focus on treating the underlying disease. And that is the mainstay of the treatment that we use for most of our patients. And if it doesn't work that way, we try to figure out what other strategies, what other consultants we need to bring in. But we should definitely try to treat the underlying disease to start. So within this subgroup of the patients we see, we have what I discussed earlier. We've got the isolated postcapillary, so predominantly a left-sided dysfunction leading to these elevated pressures and call us in pulmonary or pulmonary venous hypertension. And then we've got this combined pre and post, where we've got the left-sided dysfunction, but usually primarily due to our remodeling on the precapillary bed, secondary to sustained, long-standing, elevated left-sided pressures. We can have this remodeling and this combined pre and post picture. So the isolated postcapillary pulmonary hypertension, left-sided filling pressures are high. And what we typically see, and then what the criteria that we usually use to define this, is the pulmonary artery mean is elevated, so it's over 20, and that's the first sign that there's pulmonary hypertension. And then we've got the elevated wedge pressure, so it's telling us that we have extra fluid on board. And then what we see is this decrease, or this low, or this normal, I guess, PVR of less than 3 Woods units, telling us that this is post-capillary, and that the RV on the right side, or the right side of the bed, is not seeing any additional work or any additional resistance that it has to overcome. Then we've got the second category, the precapillary remodeling, in addition to the left-sided elevations. And it fits the criteria of pulmonary hypertension because we've got this PA mean greater than 20. And then we've got also these wedge pressure greater than 15. So we've got elevated left-sided filling pressures. And then now we've got this additional component of this elevated PVR of over greater or equal to 3 Woods units. And that tells us that in addition to the left side being elevated, now we know that the RV is seeing this additional workload, this additional resistance. And then, of course, the question is, why is that? Most likely, in a lot of our patients, it's because of the remodeling. But, of course, we have to investigate and make sure. So treatment. So for a lot of our patients, there's 2 treatment arms. The first item in our toolbox is usually volume reduction. And we've got our furosemide, our torsemide, our Bumex. Most of these we're doing in the outpatient setting, and we're titrating them, adjusting them in oral forms. But sometimes during admissions or when out in the cath lab, these are available in IV forms as well. The other item in our toolbox that we may not use as often, but is highly available to us, especially for our patients who are very complex and have a lot of things going on, are the oral vasodilators, or afterload reduction. There are a lot of them in the oral form, and we're familiar with quite a few of them. There's ACE inhibitors, and these are just some examples. By no means is this an exhaustive list of ACE inhibitors or any of these other categories. But we've got ACE inhibitors, for instance, or lisinopril, ARBs, such as valsartan. We've got our direct-acting vasodilators, like our hydralazine, that we go to, especially if someone has some underlying kidney dysfunction. We've got nitroprusside, which is IV, and a lot of times we use it in the cath lab or if someone's admitted. And then we've got other categories like the nitrodilators, like nitric oxide, and then our phosphodiesterase inhibitors. For our whole group 2 patients, and for a majority of our heart failure patients, we tend to use the first 4 when it comes to vasodilators and afterload reduction. So the ACE inhibitors, the ARBs, the direct-acting vasodilators, and our nitroprusside. So the ACE inhibitor works by blocking angiotensin II formation, and it downstream eventually decreases preload and afterload. It has the added benefit of depressing sympathetic activity, so it helps to inhibit cardiac and vascular hypertrophy and adverse remodeling. So definitely you get a couple of things for the price of one there. ARBs are very similar mechanism to the ACE, but they take effect more further downstream, so there's less of that bradykinin effect, and so less likely to have a cough, and that's why we end up or try to switch our patients to an ARB if they're having that cough with the lisinopril or the ACE inhibitor of our choice. Direct-acting vasodilators, such as hydralazine, they work by stimulating the endothelium to produce nitric oxide, which leads to, if we look at a pathway, that leads to increased cyclic GMP and vasodilation. And nitroprusside, which is an IV form administered in the hospital, so this is more of a cath lab / inpatient ICU medication, but this also works by increasing the nitric oxide levels in the blood, which leads to increased cyclic GMP, again, similar to what hydralazine does, and leads to vasodilation. It also helps to decrease overall preload and afterload, and leads to increased cardiac output. So we've recapped about the relationship in the chambers. We've talked about how we can use them as surrogates and how we can use these values to get an idea of what's happening in other parts of the heart, and then guide management. And then we focus specifically in our PA mean and how that affects our RV, And and I think this is a good time for us to go and look at some aspects of clinical application. So I think the best practice here would be a step-by-step analysis anytime we are doing a right heart cath or just looking at PA numbers. Like I said, whether it's ambulatory, looking at Merlin, or if it's in the cath lab because someone's come in decompensated. And so the first thing is to try to assess accuracy, because if we're starting out with waveforms that aren't accurate and not giving us good information, everything exponentially downstream from that is going to be wrong, and we're not going to be able to do our patients service. So starting out with accuracy, whether or not, so knowing that there should be a certain relationship between the chambers, are we seeing that? So, is the RA correlating to RV-EBP? Is the RV-SP correlating to the PSP? Is the PAD correlating to the wedge? Is there gradient? Is there any discrepancy? Things like that. Then we should take a look at the left-sided filling pressures. Is the wedge elevated? And then look at the right-sided filling pressures. Is the RA mean elevated? Because that gives us an idea of what we're working with. Someone's coming in decompensated. It's not always just fluid. Sometimes it's pressure. Sometimes it's both fluid and pressures. The other thing we want to do is we want to calculate the TPG and the PVR, because as we know, that's going to give us an idea of how much resistance, how much work, how much afterload the RV has to overcome. And so our equations come into play again. And then overall, do we have pulmonary hypertension? And if we have pulmonary hypertension, is it pre or post capillary? Is it a combination? And what do we do next? So let's look at an example of where we can use data to try to right heart cath data to interpret it and try to see what next and what's the best strategy we'd use for taking care of our patients. So assessing accuracy. We know that the PAD and the wedge should have concordance, and looking at it, is there a gradient? In this particular case, no, they're exactly the same. So then next, would we be using the PAD as a surrogate for the wedge? For instance, if we're not in the right heart cath and we have the PA measurements, most likely with this patient, because there shouldn't be a reason, given what we know about physiology, for them not to continue to be congruent. Looking at the right-sided filling pressures, RA is about 5. So this patient, at least from RV or right-sided filling standpoint, does not have an extra volume. And then we know from looking at the wedge numbers that the wedge is not particularly elevated either. It's right at like borderline. And the next thing we want to do is we want to check out how much work we think the RV has to do. So we need to calculate the TPG and the PVR. And we use those calculations. Sometimes there's like automated ways of doing it. I sometimes like to go to like MD Calc and just punch in numbers. But we calculate those, and then we see that the TPG is 7, so that's pretty good. And the PVR is 1.8, that's less than, so TPG is less than 15, and the PVR is less than 3. So we know that all of the numbers so far look pretty good. So is there pulmonary hypertension? The PA mean, which is one of the first things we look at in addition to all the other information, but that's an additional piece to basically set up the category or not. So that's borderline. So that's not elevated. That's not significantly elevated. So no, we don't have pulmonary hypertension at this point. This person's their pressures are all well within normal range. This is ideal. And there's always, so we know there's no pulmonary hypertension. Is there anything else we need to do? Is there room for diuresis? Do we want to diurese? Is there any more information that we need to get? For me, I tend to try to look at the blood pressure, see where we are with that. Is the blood pressure well controlled? What's the SVR? What's the renal function? In this case, it looks like this patient's pretty fine-tuned. But as we go on, we'll see why those things come into play. So let's look at an example that's not so peachy. So we want to assess accuracy, and it looks like there's concordance between the wedge and the PAD, and I would use the PAD as a surrogate in this case. Looking at the right-sided filling pressures, looking at the RA, that's pretty elevated, right? That's hypervolemic. So already we all know there's some extra volume on board. And when we next look at and we know that the wedge is elevated too. But then let's next look at the what the RV is seeing. So we look at TPG and the PVR, and we see that they're both actually within normal range. So is there pulmonary hypertension? There is, because we've got a PA mean greater than 20. We've got and what type is it? Well, we see that the wedge is greater than 15, and the PVR is less than 3. So this is a case of isolated post-capillary pulmonary hypertension, or can sometimes be referred to as pulmonary venous hypertension because it's on the left side. And so this is someone who has some extra volume. Is there room for diuresis? Absolutely, yes, there is. And then always, even when we have the answer, we just want to make sure, is there anything else that we need to look at? Is there anything else that's going to make a difference here? And so what are the data needed? I always like to look at the blood pressure, and I always like to know what the SVR is, just to know what I'm working with. And these numbers look great, but there may be other areas to optimize for this patient. It's always great to look at the renal function because we are diuresing and we are changing medications. So for this patient, the best treatment for them would be volume reduction. We know that the RA is elevated, the wedge is elevated, they've got pulmonary hypertension, so we'd go into our toolkit and look at our loop diuretics, and whether it is in the outpatient setting or in a situation where there's no IV access and we're using PO or oral furosemide, torsemide, or Bumex, or if we're doing this IV in the hospital setting or in an outpatient infusion clinic setting. This would be the best treatment, just looking at the numbers that we have. So let's look at another example. So we're going to be checking for accuracy once again. PAD and the wedge, are they concordant? Do they line up? Do they make sense? Is there a gradient? This case, I would say no. These look pretty similar. What about the left and right-sided filling pressures? RA is elevated and the wedge is definitely elevated, so we know we've got volume. Next, let's look and see what the RV is seeing. Let's look at the TPG and the PVR, and we realize that the PVR is actually elevated as well. That is over 3. So what sort of pulmonary hypertension do we have? It looks like we have a combined picture of pre- and post-capillary pulmonary hypertension. And I say that because if you take a look, we see that the PA mean is greater than 20, hence we have pulmonary hypertension. The wedge is elevated, is over 15. That tells us there's left-sided volume, increased left-sided filling pressures. But then what we've got is that we've also got an elevated PVR in this one. And this is what I mean when I say that things can get a little more complicated, and don't they always get complicated with our patients. So we've got someone who's got this combined picture. So is there volume for diuresis? Yes, there is. We've got elevated right and left-sided filling pressures. But what other data is needed? So for me, as I said, and you'll hear this nauseum and maybe get tired of it, I always want to know what the blood pressure is, and I always want to know what the SVR is because I want to know what I'm working with. We want to make sure that people are optimized as much as possible. So we know that there's volume to be diuresed because we've got this elevated wedge, but we also have this elevated PVR, which means that the RV is seeing an increased amount of resistance. It has to work that much harder. And so the question is, okay, after we get this volume off, is that going to be enough? Is this going to be reversible? Is the PVR going to go down? Is the PA mean going to go down? So I would, of course, start with a volume reduction because we want to get the wedge down. So we go into our toolkit and we look at our loop diuretics, furosemide, Bumex. All of us know that some of our patients, we need to give them a little boost every now and then, so metolazone, Diaril, things like that, to try to get that extra volume off. But once we have the extra volume off, are we at the point where we need to be from the pulmonary mean standpoint, from the RV standpoint? Because right now we want to focus on getting the volume off because that is key. We want to get the PAD reduced. But we also want to make sure that the PA mean, because we've already looked at the mortality associated with that, that is also optimized as well. So is getting the fluid off going to help us to get the PA mean where we need it to be? So in those situations where we do get the volume off and the wedge is 15 or less, and we still got this elevated PA mean, and we've got PVR that's still greater than 3, goes back to looking at the blood pressure, looking at the kidneys, looking at the renal function. Is there blood pressure to use vasodilators to try to get those pressures down a little further? Are there ways in which that we need to modify what we use as far as looking at the kidney function? Can we use ACE and ARBs? Do we have to go to hydralazine? Do we have to bring them in and do nitroprusside? Do we need to add an inotrope, such as dobutamine or milrinone or something like that, to give them a little more oomph so that they can get that fluid off, get the kidneys perfused? So those are just some things to think of that once we get to one step and the numbers aren't where they're supposed to be, I mean, not saying we can get things perfect, but we should always be thinking, is there something else I can do? Is there another medication that can optimize things? What else can I do for this patient to decrease their mortality? And like I just said, if we go from one to the other and we realize that, wait a minute, this PVR is still elevated, but I've got the pressures where they need to be, I've got the fluid needs to be, and now we've got a maybe even bigger gradient, then we may need to dip into another toolbox and start wondering how big a component is this precapillary contribution. Is there this defined pulmonary arterial hypertension that we need to look at things like nitric oxide and phosphodiesterase inhibitors to try to get these gradients, to get these pressures down? All right, and we're looking at another example here. And so we're going to assess accuracy. So we're seeing that the PAD and the wedge, and you guys, I know you're going to be able to do this in your sleep by the time we're done with this, but I'm going to do it one more time. We're going to look at the PAD and we're going to look at the wedge. Are they accurate? Is there concordance? Can we use the PAD as a surrogate? Yes, I would say. Left-sided filling pressures are elevated. Right-sided filling pressures are actually pretty reasonable. Let's look at the TPG and our PVR. Let's see what kind of pressures the RV is looking at. And those are reasonable too. TPG is less than 15. PVR is less than 3. And do we have pulmonary hypertension? We do. And here we are with the PA mean greater than 30, wedge definitely greater than 15, but the PVR is within normal range. It's less than 3. But do we have volume to diurese? Right? A lot of times we come in and our patients have an elevated wedge. There's elevation on both right and left sides, or we assume there is. And we go straight for diurese. But looking at this patient and looking at the RA pressures, I don't know if that's the best thing to do. What other information do we have? So go back to the blood pressure and the SVR and looking at the renal function, because that gives us a good idea of how many items, how many options we've got in our toolkit, and which do we want to pull out at this point in time? Which one would best serve this patient in this particular situation? So in this situation, not a lot of room to diurese, but if we got adequate afterload, then we can work on afterload reduction to try to get those pressures down. And as I stated before, this could be oral, especially if the patient's in an outpatient setting. But it could also be if we've got them in the cath lab already, like on the table with IV access. It's a good point to try some nitroprusside and see if the pressures change, if the wedge changes, and the PA mean goes down. And now for our final example, we're going to go through it one last time. Is there accuracy? And lo and behold, look at that. Look at the wedge and look at the PAD. There's quite a few millimeters of mercury between those two. So here we have an example where it's not quite what we'd expect in our typical heart failure patient with WHO group 2. So that's another reason why it's really good to keep looking at it every single time, because every now and then, or maybe more often than you expect, that we have a situation like this and it creeps up, and we need to be thinking about it and know how to work through it. And so we already see that there's some discrepancy there. And then if we take a look at the left side of filling pressures, the wedge is elevated. We're looking at the right side of filling pressures, and we see that the RA mean is actually not that bad. If we calculate our TPG and PVR, we see the TPG is significantly elevated, right? So we've already determined that normal is 15 or more, and here we are with a TPG of 24 and a PVR of about 4.9. So is there pulmonary hypertension? Absolutely. This is another picture where it's combined. We've got the PA mean of greater than 20, we got our wedge greater than 15, and then we got a PVR greater than 4. You know, and like looking at the discrepancy, it makes you wonder how much does that precapillary remodeling, or how much is that contributing to the overall picture of what we're seeing? So is there a lot of volume to diuresis? You know, based on what we've talked about, just looking at that RA, I probably, that wouldn't be my first strategy. I would probably move into the realm of trying the afterload reduction. So what other data is needed? You know it: blood pressure, SVR, renal function, things like that, things that will definitely influence what items we take out of our toolkit to try to take care of this patient. So, because there's not a lot of room for, not a lot of volume for diuresis, I would go straight to afterload reduction. And depending on the situation, it could be oral or IV with nitroprusside. Something tells me, given their gradient, the discrepancy we're already seeing the PAD and the wedge, and how elevated the TPG is, that, you know, we can try these, and sometimes it will be successful, but we should keep in mind that we may need to go a little bit further in a patient like this. There may be a larger component of the pre-arterial precapillary pulmonary hypertension or pulmonary arterial hypertension, and we may need to recruit others or consult or have the patient be referred to take a closer look at doing vasodilator challenges with things like nitric oxide and phosphodiesterase inhibitors. So in conclusion, I hope that you're walking away from this with a better understanding of the components of pressure, volume, and vascular resistance, and how they relate to our patients and how they relate to the treatment strategies that we use. I hope you have an understanding of right heart catheterization data, and like how vital it is that we have accuracy and that we understand how each chamber interacts with each other, and that we can use that understanding to pinpoint when we need to do further testing or deep dive, and how useful that information is, not only in just treating heart failure, but also pulmonary hypertension. We need to always keep in mind that, you know, our heart failure symptoms definitely can be indicative of volume changes, but there is also a pressure component that we need to take into mind, and that's where our afterload reduction vasodilators come in, and they're definitely there, and a lot of our patients are on some of them anyway, but they're an item in the toolkit that sometimes can be like grossly underutilized, and we all know how to manage them and to use them, and so they're very accessible. So something for us to think about when we're trying to optimize our patients, especially when we think about that mortality associated with pulmonary hypertension. And finally, I hope that you're walking with a proactive strategy of interpreting PA pressure data in order to optimize ventricular preload. I hope that you're working with a new awareness of optimizing afterload, and all in an effort to impact disease progression in our patients. Thank you.
Dr. Benjamin, a lot of stuff you just went over. I'll tell you, no one's walking away yet. The audience has been growing since we started, and there are a bunch of questions that have come in as you've been going along. So I want to get to questions that have come in from Sue and Debbie, Terry, and a whole lot of others. Just want to remind everyone that we're going to take probably about 15 minutes or so for some Q&A here. At the end of our event, a survey will pop up. Love for you to fill that out. And you still have time. If you have additional questions that you want to share and ask of Dr. Benjamin, then you can do so by getting those questions in that Q&A widget. So let me just get to, kind of to the top of where we've queued things up, Dr. Benjamin, start firing some questions your way. One of the questions came in had to do with some of the things along the lines of you talked about torsemide maybe being better for patients than furosemide. How do you decide who gets to be put on what? What are some of your kind of thoughts around that?
So for me, there are a couple of factors. If someone's naive to loop diuretics, I tend to start with furosemide and then, for lack of better terms, escalate to torsemide or Bumix just because of the better bioavailability. And a lot of patients who are naive to loop diuretics tend to respond really well, provided kidney function is okay, and provided they're compliant, because that can be the biggest issue. If there's already a history of non-compliance with some patient, whether it's because of other comorbidities, I usually start with something like torsemide because there's always a concern that when you leave the hospital, leave the clinic, there's going to be some new adjustments, and if they're inclined to skip a dose here or there, I'd prefer for them to be in something with a better bioavailability.
One of the questions I saw come in here was a clarification about your mention of SRV a couple times. Could you again clarify what that was for us and your calculations around SRV?
So the SVR, so the systemic vascular resistance, and so that is basically the equivalent, so the systemic or the aortic, the left-sided version of the PVR. So the SVR tells us how much resistance or how much pressure, how much work the left side of the heart, so the left ventricle, has to do in order to eject blood. And so one of the reasons that factors in for me is that if I have someone who comes in and I've got all the right heart cath data, and I look at the SVR and it's like 2,300, and it ranges, normal SVR varies from patient to patient, but maybe about 1,000. But if we've got double that, that tells me that implies that there should be more afterload reduction. So there's room for the heart for the vascular system to relax, because the high SVR implies that there's a lot of vasoconstriction. So when we have patients in the ICU and we put them on pressors like norepinephrine or vasopressing, what we're trying to do is vasoconstrict. We're trying to raise that SVR. For our heart failure patients, we want the heart to not have to work too much. So we don't want that SVR particularly elevated, because then that leads to more work and potentially failure. So when we get that data, the right heart cath data, plus just knowing the blood pressure, can help us to calculate what that resistance the LV is seeing. And then it also tells us if it's time for us to up our afterload medications, to get into that toolkit and look at the ACEs, the ARBs, the hydralazine, maybe IV nitroprusside, to better optimize the flow or the work of the heart.
We have Jessica on board with us here today. I appreciate the question in here, Jessica, asking when should a clinician use a PA mean versus PA diastolic to treat a patient?
And so I think ideally, and I hope we walk away from this talk using all of the information to treat a patient. And that was one of the points I was hoping to drive home. So thank you for asking that, because I want us to walk away looking at all of these components and knowing how to use them. So when we get these waveforms and we see the PAD, we look for the accuracy. As I talked about before, we look to see how that PAD correlates to the wedge, and that will tell us about the left-sided filling pressures. We should then always look at the PA mean, and because that's going to tell us a little bit about a lot about what the RV is seeing, but tell us if there are other things we need to do other than diurese or just diurese because the wedge is elevated and the PAD is elevated. Do we need to then start looking at our afterload reduction? And so I hope that we start looking, if we're not already looking at both the PAD and the PA mean, and then coming up with a strategy to comprehensively treat the filling pressures.
We'll move down our list to Terry, who's with us in the cath lab. Would you retake the pressures if the pad is 2 mmGHs higher than the wedge, or would you say they're pretty much spot on? What can you share there?
So I think that it's a very unique situation to have a patient on the table in the cath lab. And so I always err on the side of repeating it. So if you can't have too many data points and just getting an idea of where that falls. You know, a couple millimeters of mercury here and there is not the worst thing, but if you have the patient there and you can check it again, or you can zero or flush your tubing and just make sure that everything's as accurate as possible, I would take that opportunity to do that.
All right, appreciate those insights here. A question that came in a bit earlier in the presentation was asking about a patient. What if a patient who is group 2 combined, can you talk a little bit more about your strategy? Do you diurese to as normal as possible and then start afterload reduction? Do you start vasodilators right away? What's kind of your process?
So, and that's where getting the full picture comes in, and that's why I like to get the blood pressure, get the SVR, see what's going on with the renal function, because there's multiple pathways for that scenario. If a patient comes in and their volume, they've got pre and post, I usually start with trying to diurese them as long as there is room for that, as we talked about. So as long as there's right and left side filling pressures, that would be amenable to doing that. And sometimes, depending on the patient's situation, you can get vasodilation and end up with a diuretic effect if you use things like inotropes like dobutamine. But I usually start with the diuresis and start to get that forward flow, and then see if I need to use vasodilators, and then see if that precapillary elevation needs a little bit more as far as the phosphodiesterase inhibitors and whatnot. But I usually start with diuresis. If there needs to be augmentation for the diuresis, for instance, if the blood pressure is not the greatest, the kidney function is not the greatest, then I start to think about things like, do I need to add an inotrope, such as dobutamine, to help give the heart that extra oomph and give the kidneys that needed blood supply to be able to diurese effectively.
I have a team on board here listening to today, Dr. Benjamin, that does have several CardioMEMS patients, and so this is something that came in from that group saying it seems like when we think of pulmonary hypertension, we think group 1. It seems like most of our patients have group 2 pulmonary hypertension. Does that mean that most of our CardioMEMS patients are at risk of RV failure unless we intervene?
Absolutely. And I'm glad you asked that, because that means that you're paying attention and you're walking away thinking about the things that we hope you think about at the end of this talk. I think that in an ideal world, we are able to diurese patients or WHO group 2 patients and get the filling pressures down, so get the wedge down and have the pulmonary artery mean also reduced. But that's not always the case, and that's probably not the case in a lot of our patients. And so, yes, our LV failure patients or our WHO group 2 patients are at risk, because that elevated PA mean means that there is sustained RV work. So that means that the resistance, what the RV is seeing and what it has to work against, is elevated throughout that time. Whether or not the wedge pressure seems to be ideal, the RV is still having to work harder to try to compensate, to try to have forward flow. So absolutely, if the mean is elevated, we're still running that risk, and that's something that we need to address, whether it's using the strategies that I talked about today, or having a consultant, or referring a patient out for further assessment. But it's something that we need to acknowledge and try to treat, and try to be efficient as far as, or expeditious as far as, getting the patient to the treatment that they need.
Dr. Benjamin, I'm going to call out your contact information that's on the thank you slide right now. So if anyone wants to jot that down to stay in contact and follow you, they can. I also want to let you and everyone else know we've got about 5 minutes left here. My plan is 2 or 3 more questions, And then once we address those questions, I want to turn things back to Dr. Benjamin and have her give us kind of that one to grow on, that one to think on. What's another kind of next step that we can all participate in as we eventually do walk away from today's event. So that's what we'll do in the final few moments here. That moves me to Shadi, who is online. Question coming in: does the PA systolic ever matter if you are only using mean PA and PAD in CardioMEMS and clinical management?
Well, the PA systolic matters just by virtue of being part of calculating the PA mean, right? So there is a relationship there, and it's proportional to the changes that we see. The PA systolic is particularly important, or particularly impactful, I should say, when we're looking at a patient who is now euvolemic, in the sense that the RA filling pressures are good. We got that wedge down, whether it was diuresis or with afterward reduction. And then now we've got this even larger gradient, right? We've got a really high PA systolic pressure and a really low PAD, because we've gotten rid of that additional LV component. And here we are with someone who still has elevated PA mean because the PA systolic is that elevated. And so it's definitely important. It's an indication of what the RV systolic pressure is, as we talked about before. So it shows you how much work the RV is doing, and also how much pressure, just by relation to the mean, the RV is seeing. So it is impactful in that way.
Let's take a look. Again, this question came in a bit earlier in the event here. Deb out there asking, what is a typical dose of loop diuretics? How high of a dose will you go with loop in face of pressures not coming down before you say, you know what, this patient may need, if it's safe to do so, may need a different plan of attack?
I may not be the best person to ask, because I can get pretty aggressive. So as far as the highest dose I would use, so the dose is very important, but it's also extremely important in the setting of the other factors I talk about, like the blood pressure. And very significant, very impactful is the renal function. So if someone's coming in with an elevated creatinine, and they're volume overloaded, I'm not going to do orals. Especially because they're probably not absorbing it that well at that point, because they probably have a lot of gut edema. But two, I'm going to need to try to overcome that kidney dysfunction. And so I'm going to go to IV diuretics, and I'm going to go for IV diuretic that I think is going to hit that threshold. So barring, any other issues, I personally, and so this is maybe off-label, off-brand, but I personally usually start with 80 IV of Lasix. For my patients coming in who are being admitted for diuresis. In the clinic, orals, if I'm at a point where I'm doing PO diuretics twice a day and I'm going up on them, I usually switch to something like torsemide. And so that goes back to bioavailability. But a lot of times you get to that point, you probably need to do some IV diuresis so that they can absorb even the torsemide. When I get to the point, it's other part of the question of thinking about needing to do more. If we are struggling to get the volume off, especially even with IV diuresis, the kidneys aren't necessarily completely in the game. Then I start to sit back and think, what else do I need to do? So one, we want to make sure that the volume status assessment is accurate. So if this is someone that doesn't have a SWAN or doesn't have a CardioMEMS, we want to make sure that we are diuresing, we are trying to take off fluid that's actually there. And that's where the physical exam can get tricky with some of our patients. But, if there is definitely volume on board and we're not able to get it off, being very aggressive, putting them on a Lasix strip, I've done as much as IV furosemide 100 and a Lasix strip of 20 or 25. So, like I said, sometimes it can be aggressive, but I know people who are more aggressive. But if we're doing that and we're still struggling with the kidneys or struggling with blood pressure or we're not getting the fluid off, then we need to start thinking about inotropes and getting a SWAN in. Or if they don't have a SWAN, or if they don't have a CardioMEMS, then we need to start thinking, how are we going to augment this cardiac output? Because a lot of times that can be the issue in our patients, especially if there's LV systolic dysfunction, especially if there's already some underlying cardiorenal syndrome, that we need to add that little kick so that the heart can have more forward flow and perfuse the kidneys and get that fluid off. So I think about, trying to looking at the kidneys and making sure that we're giving the appropriate dose so we can hit that threshold. Whether it's IV or PO, I use metolazone and Diaril often if it's outpatient setting. But then I also think about, we want to make sure that the volume status we think we have is the one we're working with. So that's where PA monitoring comes in, because it's very helpful as far as when we've hit our threshold or whether or not we're working with something else. And then I think about, how do I augment contractility? And is that what would be useful in this situation? Do the kidneys need more perfusion? And so those are kind of some of the thoughts that go through my mind.
We appreciate you sharing those. Last question to you, probably a minute on this, and then we can go into a minute on kind of a one to grow on as we look to wrap things up here, Dr. Benjamin. The question was, do you have a system to determine short and long-term target goals for your CardioMEMS patients?
Do I have a system? So I think that each program probably has their way of dealing with patients, and then on that level, even on a more finer level, each patient is an individual. So so what are the numbers? The right heart cath, the initial right heart catheter implantation is key, and that's why I hope everyone is putting that into Merlin and they're referencing it when they're coming up with their treatment plan. Where am I starting from? What's the starting point? What's the PAD? What was the wedge? Was there any gradient? What's the correlation? And that kind of sets up what we're going to start with, like how we're gonna how aggressively I'm gonna diuresis them initially, and then it kind of gives me an idea of expectations along the road. If someone's PAD is starting out at 40, I expect a pretty significant changes, over the next week or so, because I should be aggressively diuresing them. The PAD is 25, that might be a little different. So we initially, of course, we monitor everyone every day when we initially place the CMEMS. But we don't expect to have, for most patients, we don't expect to have gotten to that optimized within that threshold until after the first few weeks or so.
To Chen and Ivy and everyone else who's submitted questions, we're going to wrap those up in a report on our end. We're going to share those with Dr. Benjamin as well as our team, our Abbott team, and we'll look to try and get some responses out to you. But Dr. Benjamin, the final thought, something that you'd like us to all walk away with, and then we'll be closing things down for today.
So if there's only one pearl that you walk away with, I think it's looking at your toolbox. Looking at all the things, all the options that we have as far as treatment for our patients. We're not just limited to the loop diuretics or the metolazone. There's a lot of other ways in which that we can manage our patients. So looking at the numbers that we got in the right heart cath or in the CMEMS, and then going to our toolbox and seeing what else should we be doing? What else needs to be done based on all these options that we have available to us? The other thing, I guess, which is a little bit of an attachment to that, is that definitely look at the other factors. So we've got the PA pressures. What else is going on with the patient? What's the blood pressure? What's the kidney function? Because they also go a long way in deciding not just what the next step is, but what we can use in our toolbox. Do we need to get other people involved, whether it is a pulmonary hypertension specialist or is a nephrologist? So those would be my parting words. What else is going on with the patient? And what's in our toolbox, and have we utilized our toolbox to its full potential?
It has been a full hour of great information. Again, Dr. Terry Ann Benjamin has been our guest here today. Really do appreciate the time, Doctor, spending on this and sharing with all of us. Folks, on behalf of the team at Abbott, really do appreciate all of you taking time to join us for this event. As we do wrap things up, again, a brief survey is going to pop on up for all of you. Really appreciate you taking just a quick moment to fill that out for us. Gives us feedback on our events so we can continue to bring you strong information like everything that you heard here today. With that, we are going to wrap things up. We do look forward to working with and talking to all of you down the road on future webinars.